Hello, and welcome to today's webinar, Public versus Private, an in-depth comparison of health insurance exchanges for health plans. Before we get started, I would like to announce a few brief housekeeping details. Today's session is being recorded, and an online archive of today's event will be available a few days after the call. You will receive an email from AHIP in a few days, and that will ask you if you would like to receive the archive. Please respond to the email if you would. I'd like to remind you of AHIP's antitrust statement and ask that you reference to it in the conference materials under the Handouts tab. Please keep in mind that you may also ask a question any time during the presentation by typing your question into the chat box located in the lower left-hand corner of your screen and then click Send. We are very fortunate to have with us today Eugene Sayan. Eugene Sayan has 20 years experience and brings extensive expertise in business process management and content management. He has an extensive track record in leading companies to success. Prior to Softheon, Mr. Sayan successfully led second-generation imaging, document management, and workflow initiatives of various content management companies. Mr. Sayan is recognized as an industry leader, frequently speaks at industry events, and has published several articles in the field of content management. He serves on the Stony Brook University Computer Science Advisory Board and is a member of the Board of Directors at Long Island High Technology Incubator, where he contributes to the growth of technology-based startup firms. He has a master's degree in computer science from New York Institute of Technology and an undergrad degree in electrical engineering from the Istanbul Technical University, Turkey. At this time, I would like to turn the floor over to Eugene.
Thank you very much. We are delighted to have you with us this afternoon. This is one of a series of AHIP webinars that Softheon puts together. We hope that you will find the next hour informative as we dive into the specific details and discussions around the exchanges. Without further ado, we'll proceed with a brief overview once again. As we all know, the healthcare industry is about to undergo significant changes with the implementation of Affordable Care Act, or ACA. And the creation of federally facilitated exchanges and state exchanges and private health insurance exchanges are the main drivers of these efforts. The states are considering options and already have already announced that some of them will be implementing their own public benefits exchanges, and the others have chose to leverage what we call the federally facilitated exchanges. So in this webinar, we will examine the complexities behind both private and public exchanges, and then we'll be able to offer some best practice approaches, perhaps for payers to integrate with these exchanges. What is an exchange? An exchange is the Webster definition of exchange is basically the act of giving or taking one thing in return for another. But perhaps in the context of today's webinar, we will probably refer to the next definition, which is a place and an organized market or center for trading in securities or commodities. In this case, we'll be referring to healthcare product and services. What are the exchanges? Some of you already, if not all of you, have experience perhaps dealing with making an online reservation through products like or websites like Expedia or Travelocity. These exchanges have been extremely successful bringing and aggregating different types of products and services as it relates to the travel industry. But we also know that there are the airline carriers, what used to be a single carrier website once. Now, through the collaboration of star alliances, that it is not uncommon to make a reservation through Delta's website, which one leg of the flight might be on an American Airlines. So the Star Alliance notion of exchanges, even in a single carrier context, inherently supports multiple choices and multiple products that are being presented to consumer in a single unified manner. But there are also other types of exchanges for in production for quite some time. Perhaps one of the most successful one is also referred as the Federal Reserve Wire Network, or FedWire for short. FedWire is a real-time gross settlement funds of transfer systems operated by the Federal Reserve. In 2007, the average daily transfer of funds through the FedWire was about $2.7 trillion. Within 2 years, in 2009, that transfer amount has reached the $631 trillion. This could be very well the pattern that we may experience once the exchanges become a norm of, again, buying and servicing healthcare products. What makes the exchange successful, however, is always been the notion of standards, and the exchange standards, also commonly known as, historically, the software standards are being managed by the organization like ISO and ANSI, American National Standards Institute. However, within the last decade or so, has seen the rise in importance of industry consortia developing standards and specifications. Including within the healthcare community, as you know quite well, the Accredited Standards Committee, ASC, X12, develops standards, the EDI specifications, which is the underpinning data elements or data exchange between the payers and the provider community. There are other types of exchanges, as you well know quite well, especially a court. It is the primary means of facilitating the development and use of standards for the property, life, and casualty insurance and related to financial services industries. There are other types of exchanges, as you know quite well. The FIX, the Financial Information Exchange, or SWIFT, that's the Society for Worldwide Interbank Financial Telecommunication. The NIAM, N-I-E-M, is one of the perhaps the exception to the PPACA or ACA or ACA, is being mentioned by name, the National Information Exchange Model. NIAM is a partnership of the U.S. Department of Justice and Department of Homeland Security. It is designed to develop and disseminate and support enterprise-wide information exchange standards and processes that enable the jurisdiction to effectively share critical information in the emergency situations. So there are quite a few well-established exchanges out there. However, as you can see, is what is really driving the success of these exchanges is what we call the industry consortia. We will touch upon this topic throughout the webinar. We are predicting that there will be some challenges associated, disparate implementations or disparate technologies used by the various participants or stakeholders of the exchanges. Let's proceed to the topic of health insurance exchanges. Dan Schuler, the director of Leavitt Partners, the firm, he was under the Governor Leavitt when he did the Utah implementation. As he described, basically the health insurance exchange is an organized and transparent marketplace for consumers that facilitates the buying, selling, and administration of health insurances. For decades, the U.S. companies that offer health care benefits to employees have stuck to a defined benefit model in which the company offers a standard set of health benefits and shoulders most of the financial burden and a risk of healthcare cost. The healthcare reform especially aims to make health insurance more affordable for individuals and small businesses. However, mid-sized and large employers might decide to use these public exchanges to control their own costs, therefore terminating their existing insurances and routing their employees to these public exchanges. We also predict that this will compress the payers' margins and force payers to respond defensively with alternative solutions such as defined contribution plans and private exchanges. Private exchanges has been around for quite some time. This is not anything new. Starting mid-90s, mainly targeting the small and large group markets. So private exchanges are marketplaces of health insurance and other related products. as it refers that they are privately owned and governed, and typically operated by the insurance brokers and benefit consultants and insurers. Employers purchase health insurance through the private exchange, and then their employees can choose a health plan from those supplied by participating payers. We can, all practical purposes, as also being underlined by Booz Allen, is that there are two types of private exchanges. One we call the single carrier, the other one is the multi-carrier. In the single carrier strategy, a single employer or a carrier perhaps establishes their own exchange and offer a wide variety of products that are related to that one carrier most of the time, or that are related to that particularly perhaps an employer, and through a single insurance carrier or third-party administrator, funded through an HRA or some other funding mechanism. In the multiple employer approach, the multiple employers can come together, effectively increasing the employer's risk pool and fund through, once again, an HRA or some other funding mechanism to purchase a fully insured group health plans that are available by multiple insurance carriers through a private exchanges. As you can see from the slide, is that there are several successful single carrier or multi-carrier exchanges in place. Bloom Health and Blue Cross Highmarks, and on the multi-carrier side, ehealthinsurance.com, Extend Health, and FP Health. There are just a few to mention. Private exchanges facilitate the migration to a defined contribution model, which we'll talk about very shortly in detail, while allowing employees to return some involvement in their employees' health care. Other main features include the contractual requirements for insurance and bundling the human resources functions and other benefits. And the rate and risk sharing is always group related. And the typical mid-size or average size of private exchanges that are existing operating today is in the vicinity of anywhere from the several thousand to 150,000 membership organizations, NFB being the one of them that we are personally familiar with. So private exchanges, what is a defined contribution? Well, the defined contributions is basically where a health plan that the employer makes a fixed contribution and simply makes a selection, and subsequently employees may have to purchase a defined benefit. So therefore, the private exchanges are flexible and can be customized to address the needs of an employer group, unlike public exchanges, which are targeted to individual or small groups. For instance, private exchanges can design benefit tiers specific to employer segments with robust multi-channel employee decision support. Another advantage of the private exchange that can be offer a broader range of detailed products like dental, life insurance, or even non-insurance products that the public exchanges at this point in time are not ready to offer. One exception perhaps could be the California's Health Benefit Exchange, which has already made a statement that the California Public Exchange will offer complementary products, perhaps HRAs, HSAs, even COBRA. Private exchanges can operate with or without defined contributions, however. But this webinar will focus on the private exchanges and with their defined contribution elements. So the private exchanges, the employee choice is a process strategy. It has been defined that employees and employers will have a choice to health plans and benefits design within the exchange. And we would like to spend some time on this slide. I think there's a lot to cover. There's a lot to discuss in here. Private exchanges enable the healthcare consumers to shop from among a wide variety of major medical health insurance products with varying plans and designs. And this includes offering of up to 10, sometimes 20 different medical plans, ranging from high-cost sharing plans down to the low-cost or no-cost sharing plans, with cost differentials of up to 60%. Promoting choice and consumerism has been proven to reduce the healthcare spending and improve customer satisfaction. Offering a wide variety of major medical plans is a departure from the current model. This approach also differs from the offerings under, for example, the state-based or federally facilitated exchanges. In this model, the option one will be the employer chooses an insurer or a tier related to the defined benefit, and then therefore requiring its employer to make all the choices for his or her employees. In the option 2 model is that the employer chooses an issuer and the employee chooses a tier, providing that employer chooses which health plan will be made available, allowing employees to choose from the coverage level they prefer. In option 3, the employer chooses the tier and the employee chooses issuer, providing that employer chooses the coverage level for all employees, but allowing employee to choose their health plan from the available options. In option 4, the pairs of defined contribution and choice requiring that exchange to negotiate a paired options, which the employer will choose to make issuer available to his or her employees. And finally, the option 5 is that the full employee choice, whereby the employee will choose among all options available within their geography and limited by the contribution level made by the employer. This particular strategy, the employee choice, is a critical aspect or component of public exchanges. Once again, making the references to California exchange, the California chose to make their public exchanges also following the option 5, giving employee the complete control over the selection of the tier as well as the carrier selection through the public exchanges. Public exchanges. As you all know quite well by now, that there has been 2 successful public exchanges in operation dating back to 2006. Back in 2006, Massachusetts passed a legislation to formation of an Affordable Care Act in their own respective states. Both the Utah and Massachusetts provide an individual to small group insurance through the web technologies portals. However, the adoption of the web technologies, for instance, in Massachusetts, has not really tempered. It has been increasing over steady. Nevertheless, most recent numbers that we hear, it's still in the high 20s to the maybe low 30s. The significant portion of the interaction with the consumers, it's still through the conventional call center or other forms of communications. Both state exchanges certify the health plans that participate in the exchange. They also present, especially Massachusetts, present the options in a standardized way. In fact, the notion of the metal levels, the platinum, gold, silver, bronze, was in fact first defined within Massachusetts. And this is their way of just defining the quote-unquote tiered essential health benefit programs in various degrees. Both the state exchanges provide a web resources, including possible cost calculators, toll-free call center. Utah has a very smaller operation headcount-wise. I'll give you some references again in Massachusetts that the call center operation, it's in the vicinity of nearly 50 to 75 people. So it is a sizable operation, and in a given day, and they take quite a few calls, and we'll get into the next slides. Both the exchanges administer the exemption process for individual mandates, including the subsidy calculations and whatnot. And the eligibility is determined based on the FPL levels. Also, that it facilitates the advance payments as well as the premium payments. The premium billing system provides the capability to aggregating the payment processes, including subsidy and premium clients. Massachusetts has not been, I must confess, has not been too successful in the group market. You can see in contrast to the individual enrollments. The employer-sponsored insurance is affordable. Is however that its traction, so to speak, traction has not been as successful as perhaps some of the critics point out. The receive and process of free choice vouchers for employees with unaffordable employee-sponsored coverage is also being provided. They both operate a consumer assistance, perhaps a early definition or early version of a navigator program. In the Massachusetts example, it is an outsource, is a business process outsourcing operation that the contract was been awarded to a leading BPO vendor for the last since its inception. I have the great opportunity and privilege to working with some of those people since 2008. So we have been, again, proud and privileged to have a day-to-day insight and lessons learned from those experiences. More in detail on MassHealth Connector, perhaps. Again, just for that discuss, this is what we are more familiar with it, and it's more relevant to the topic of ACA. As you can see from this slide, is there the technology it's been used is a COTS technology, meaning commercial off the shelf. Build versus buy model. We decided to, or I should say, the state decided to purchase an existing platforms. And so is the premium billing technology has been in place since 2008. On a given day, we receive a significant number of calls. On a monthly basis, we receive nearly 42,000 calls. We handle a significant number of mailing of all kinds of communications, including the welcome kits and the fulfillments and whatnot. Again, full-fledged call center with the full IVR capabilities, ability to connect to the Medicaid Management Information Systems, MMIS, or an earlier version of MMIS, MA21, for the benefits eligibility and enrollment process. It is as you also know, that there has been announced that there's going to be a 3.5% basically a surcharge surcharge fee for the cost to cover for covering the operating cost of federally facilitated exchange, and as of right now, that the FFE's model perhaps will be trickled down to the states, and which may end up actually going down to the payers. Ultimately, consumers are going to end up paying those fees. In Massachusetts, Health Connector historically has relied mainly on state funding to cover the cost of running the program. In 2012, there was $25 million of its $36 million budget came from the state treasury, and $6.9 million came from a surcharge on the insurance policies sold in Massachusetts through the exchanges. Let's direct our attention to perhaps the next few slides about the Accountable Care Act and what it really means as it relates to the public and private exchanges. As you all know, March 23rd, 2010, President Obama signed the Accountable Care Act, or ACA, into law. As a result of it, it is estimated that 49 million uninsured people will be covered some shape or form. Expanded coverage to the individuals will be nearly 32 million. And the mandate also requires definition of an essential health benefits and the standardization of the products. And I'd like to take a moment, maybe we'll discuss it maybe in the next slides. But in the commercial world, it is something that kind of an anomaly. Recently completing a project for a rather large Northeast carrier, we have discovered as part of their Summary of Benefits and Coverage, SBC, which is one of the first mandates of ACA. We discovered that this particular health carrier had 13,000 products, and the plan or product information was scattered across nearly 30 different databases. So there was not a single source of truth, and then there has to be some inherent cost, as anyone can guess and estimate at this time. The ACA will also provide the premium for the subsidies, and again, it's expected or projected to be 24 million people will enroll into health plans in some shape through the public exchanges. As you all know quite well, that the other portion or significant portion of the ACA will have a reliance upon the state systems, including the state Medicaid operations. Many states are looking to enhance and improve their existing infrastructures, many of them pursuing integrated eligibility systems or more cutting-edge technologies such as asset verification system for the real-time eligibility and elimination of fraud and abuse from the Medicaid entitlement programs. So states are prone to or already been following a separate parallel track about modernizing their MMIS and eligibility systems that can be fully integrated and support with exchanges. One once again, in that context is that the way the ACA designs or ACA defines the exchanges is that the original law of the exchange intent was to create it, was not to deliver subsidies, but rather to serve as a marketplace. And it's believed that the exchange will reduce the administrative cost. And if you look a little further down, in fact, the initial roadmap or initial model for the exchanges, it wasn't the Massachusetts Connector model, but in fact was the private exchanges as means of marketplaces. Today, currently, ACA defines 3 types of public exchanges. As you can see, all the way from the left to right, it will be we are referring to the public exchanges. These are going to be state-based exchanges, and state-based exchanges. There are nearly 14 states have already signed up. We have a slide coming up shortly, and we'll talk about that. And some of the other states also choose to pursue the route of state partnership programs. In that context, that state will be operating in jointly with the federally facilitated exchange, which will basically implement the brunt of the work of, especially on the IT sides. So with the elections results jump-starting the exchanges, and then all of a sudden the significant amount of activities, obviously, it is creating a somewhat of a, so I'll say the word in here, a chaos within the industry. And this kind of unknown uncertainty is already even it's visible at the federal level. Initially, there was a December 14 deadline for the states to submit. Initially, I will say actually November 16. Submit the declaration of letters to whether that to be participating in a state-based exchange. Now that deadline has now been extended to February 15 for the FFE state partnership submissions. Another type of activities is occurring at the administrative or governing level. Recently, Gary Cohen is joined back to CSIO, which is the organization ultimately oversees the significant portion of the ACA or public exchange implementations. He came back after a while, pursuing some opportunities up in California, and Gary was originally ran the organization for the period of intense activity implementing the MLR and rate review regulations. If you had a chance to join the HIPFL forum, Gary was kind enough to give the audience the state of the CSIO and then the next steps. I also want to point attention to the fact that his predecessor, Steve Larson, left the CSIO and to become an executive vice president of Optum Insight, which is a United healthcare company. And another noteworthy development there is that the QSSI, the company that was awarded with a contract by CSIO to implement the federal data hub, is also being acquired by Optum Health. As a result of these developments, Senator Orrin Hatch is demanding a hearing to go over the list of vendors and the complete list of vendors who are being contracted to participate in the state exchanges, and the more details perhaps to follow. Once again, there is a coordinated effort. We will call it in this case perhaps not an industry consortia, but it will be more of a government consortia. As you will imagine that every state pretty much who's looking to build their state exchanges will go through the process of ultimately pretty much doing the same thing. To elaborate, to encourage the state to collaborate with one another, CMS has established a program, CALT, Collaborative Application Lifecycle Management Tool. CALT is a centralized platform and provides its features and functions to all users, mainly the states, regardless of the geographic location. CALT collaboration features states to manage system development activities related to the planning, developing, testing, implementing, and maintaining numerous Medicaid and exchange-related IT, software, hardware systems, and to communicate their progress and innovative ideas with other states. States can also share best practices and post documents such as MIDA, state self-assessments, through the use of CALT. CMS will provide states with timely feedback and direct support for systems development projects. Additional benefits of the CALT environment are the kind of wikis or Wikipedias or online dictionaries for managing and searching exchange-related content, project management tools, providing ability to track progress, managing the risk and issues, and being able to collaborate with other states who are in the similar type of a timeline or processing. And transparent and the collaborative space, including the test cases or use cases, how individual states are proceeding with their implementation or integration with federally facilitated exchanges and federal data hub. Clearly, as you can see, even though it may appear to be some confusion, there is a coordinated effort on the CMS's part to making sure, to their best attempt, to their best effort, to making sure that the state exchanges are successful and the federal facilitated exchanges are being the kind of the driver of that effort. CMS and CCI also proceeded to define the critical key pieces of the technologies. There are multiple sources. You can directly find them out of the CMS website. These are also commonly referred as 7 conditions and standards. CCI and CMS has defined that state IT implementation of the health benefit exchanges or other types of exchanges for that matter to highly encourage to follow these guidelines and standards. Once again, these are not mandates, they are just guidelines. Given the fact that the Federal Data Hub will be embodying into many of these guidelines, it will be significantly beneficial and mutually beneficial to states to adopt the models. Noteworthy ones, the MIDA conditions that subjects or demands that the states to perform annual self-assessment or concept of operations to move towards a batch-oriented aging systems to the more real-time systems. Modularity standards, asking states to choose technologies that are based on open standards, business rules engines, and repositories. Industry standards, making sure that the product that are chosen follows the HIPAA Section 508, the Rehabilitation Act, or 1104 or 1561, the Electronic Eligibility and Enrollment. Highly encourage the states as well as the other related entities to leverage condition, which is to asking them to buy commercial off-the-shelf products. These products do exist that are being used in the other industries like financial services. Business results condition refers to the degree of automations and the raised awareness of notion of service level agreements that are being widely used in the private sectors. Making sure that the stakeholders in the exchange, they are adhering to the same rules and regulations, to the performance standards based on business processes. And the reporting condition is a guideline around oversight, administration's evaluation, integrity, and transparency of these state exchange benefit implementations. Finally, the interoperability condition highly encourages the state to adapt technologies around exchanges, such as cloud, such as web services, and such as integrated eligibility systems. One note, just a quick make a note about that. I know that kind of cloud technology has always been concerns and issues around its deployment, especially in the healthcare payer market or in general within the healthcare market altogether. Federal Data Hub will be probably our biggest cloud implementation. It's being basically initiated by the federal government. It will adhere to the cloud specifications like web services component to it with full respect and compliance with HIPAA rules, things like encryption at rest, encryption in transit. As the data flows through these, quote unquote, the public internet, The data will be encrypted to the highest degree. Nevertheless, the cloud computing, the cloud ecosystem has arrived. It's starting with the federal data hub. We will see more and more implementations. So let's take a look at it where the states are, how the states are doing these days. As you can see here, this slide, it needs an update. I did request our friends from AHIP, my good friend Candy, to provide me. She has kind enough to share one at the recent fall forum. But in summary, there are nearly 16 states are proceeding with their plans to implement their state benefit exchanges. 6 has already announced that there will be in a state partnership exchange. In other words, they will be partly responsible, perhaps responsible of the QHP certification process, and perhaps partly responsible of the billing, premium billing component to it. But they don't really want to make any significant investment, anything beyond that. And then the remaining 14 of it already announced that they are going to be on the FFE, and the rest are right now has not made any decisions, and this numbers obviously change on a daily basis. SBEs, the state benefit exchanges, plans to use the federal identity proofing service offered by Experian. This is another new, in a way, that a commercial off-the-shelf product. For those of you familiar with Experian, I'm sure that if you have ever looked into your quote-unquote your FICO scores, your credit scores, or last time you purchased a house or a car, Experian is the authority that provides that level of authentications or the identity management. Experian provides the questions to the customers and will verify it against the data available, enabling exchange to confirm the individual's identity. In 2004, Gary disclosed that information at the fall forum that there will be no fees to states for the use of Federal Data Hub. And we expect that that will be the condition in any event, any shape or form, if it ever needs to be propagated down to the private payers as well. For the states that are waiting, another dilemma that's being basically another predicament is being defined is that as the states wait a little longer, what we are seeing is there among the vendor community or technology vendors, the lack of A teams. In other words, that it might be the greatest technology, but even the large organizations like Accenture and Deloitte, they are heavily consumed with their state exchange implementations, and this has only begun. And we are seeing that the news around more like, the technology vendors kind of putting their farm teams to implement the subsequent state implementation or exchange implementations. One of the specifications of or mandate within the ACA is the accreditation process. In that front, both the NCQA and URAC has already made an announcement that they will be accrediting the health insurance exchange products as it becomes available. So as a case study, we would like to discuss some of the activities or the guidelines put out by at the state level, California Exchange. Again, some of them will make references to the federally facilitated exchanges, but California has put together a fairly robust, fairly comprehensive state exchange operation. And many of these exchange components, by the way, it is being agreed and based on our personal interaction with the MassHealth Connector, and many of them are combined. As you can point it out, this kind of color-coded, color-shaded. The first group is that the first group of products and services that the exchange will provide is the plan management. It's towards the standardization of the products that are being sold through the health exchanges. It will be a utilization of a standard format for presenting the health benefit plans options on the exchange to the consumers. The basic premise is about the definition of the essential health benefits, There are varying degrees of definition of essential health benefits. One being that, for instance, that some questions and still there are some unanswered question, I should say. One being the dental care. Pediatric dental care is by ACA defined to be a part of the EHB. However, the dental plans are not considered to be an essential part of an essential health benefits programs. As part of the plan enrollment process, this will give the carriers the ability to submit their quote-unquote to become a qualifying health plan. The processes like certifications and recertifications and decertification and appeal processes, they will be all handled within the context of a plan enrollment and management system of the state exchanges. The portal itself obviously plays a great role. The exchanges are heavily relied upon, no different than, and no surprise, than the Expedias of Travelocities of the world, and how much their business or portal-driven versus the traditional channels. To maintain a consumer's website for individuals to compare the standardized information on plans, to determine individuals' eligibility, as well as calculating their credits and premiums, and to help them enroll into one of those qualified metal tiers, and finally to obtain customer support. Those are among the main features or capabilities of the portals exchange portals will provide. The eligibility process will be is a process of collecting the basic demographic information and subsequently determining the income level of that individual so that the subsidy levels or the cost-sharing models can be defined. Exchange will pass this information most likely with the Department of Revenue or state IRS systems, and at the federal level with the Federal Data Hub if there needed to be. And once the data is defined and then the tax credit and cost-sharing subsidies are defined, an individual will then be able to allow to participate and enroll into these programs. The exchange citizenship, immigration status, info with Social Security Administrations and Department of Homeland Security will also be used to define and verify eligibility for those consumers to use the exchanges. The process is expected to be extremely streamlined and near real time. The experience that is being projected is very similar to today what we do with our online property casualty, life, or even car insurance as we go out and buy these products. The financial services, as obviously the heart of the system in our view, will be the premium billing component to it. Obviously, there are many details that we can dive into it, and probably we'll have a lot more. We will need a lot more than 2 hours. Advanced payments and cost sharings and whatnot. There is the notion of the premium billing aggregation, if you will, and even there is the notion of clawback. The clawback basically refers to that the individual subsidy levels will not or shall not, and most of the time will remain the same as they purchased the plan, as they enrolled the plan at the beginning of the year. If those individuals go through a kind of churning process, depending upon their employment status, depending upon their income status, that the subsidy is a ongoing activity, subsidy calculation that I'm referring to. So there is a provision in ACA about that, IRS having the opportunity to come back and to those consumers and demanding a payback because they are now in a perhaps a different subsidy bracket than what they were when they were first enrolling into these state exchanges. The consumer care portion of it will be available through a call center. The California is also looking to implement a multiple call centers, possibly, or another option is that they're creating a single call center, however, addressing the diverse needs. Also, California made an exception, once again, creating multiple regions as if creating a mini exchanges within the state itself. Administrations, operation, and compliance, obviously always a critical component, will be a critical component of exchanges. Certifying, the decertifying, again, as I said, the decertifying the health plans as qualify. the elements of Department of Insurance, Health and Human Services, or even the different state criteria. Assigning a quality rating to each plan using the criteria developed by HHS. There is a significant emphasis, in fact, maybe possibly using some of the claims data, very much like the star ratings, that the plans will be then kind of rated throughout the year in order for them to be able to obtain and retain their QHP status. The employers will be then notified through the groups. As you all quite well know that the current ACA provisions is that the limits the small group enrollment through the SHOP exchanges to 50 people, and that number will go up to 100 people beyond 2016. That will be I believe will be left up to states. So within that context, that the exchange may need to reach out to the employer groups and being able to communicate and make sure that they are being addressed and issues that are being raised by them that are being addressed. Finally, another new concept that's being brought in with the ACA is the notion of the navigator programs. Once again, the navigators could be community-based organizations and providing different types of community outreach services. A church groups could be a community, a navigator, for instance, within the exchanges, a chamber of commerces, or even the unions. The employee unions could become a navigator. Now, the California made a point about that they will not be commission, the navigators will not be receiving a commission. However, they are entitled to some reimbursement for the type of services that they provide. Another interesting point about the California about that the brokers commission. The last that we heard was actually the exchange will be paying the commission to the brokers directly, rather than the carriers itself. Now, at the full forum, Gary pointed out that basically the FFE, however, will not follow that model. FFE will still leave the relationship of the brokers and the carriers to the way it has been so far, and that kind of begs the question to be answered: where the brokers' incentives will lie, where they're gonna do. The California making a significant attempt to make sure that the exchange is successful, and therefore they are quote-unquote enticing the brokers to sell the exchange product before they go out and sell other type of products that are available from the carrier in the commercial context. The very first thing that the carriers now has to face is what's called the QHP. How do I become a qualifying health plan? And submitting the quote-unquote the different products matching the essential health benefits. So as an active purchaser, California Health Benefit Exchange has already issued an RFP for carriers to respond. And you're looking at some of the timelines associated with. And as you can see, the plan selection process will probably go all the way into, I will say, probably end of even Q2. That's the time frame that I think that we will know then exactly which plans will be then are allowed to participate and sell their products in the given regions within the California Exchange. Once again, the QHP process is a process of exchange to certify products, make sure that it complies with the essential health benefits package, and make sure that it's offered by the insurer that is licensed and in good standing in each state, agrees to offer at least one silver plan and one gold plan, and also agrees to charge the same premium whether the plan is sold the exchange or outside the exchange. So in California, a plan of its kind, a similar comparable plan, has to be exchanged by definition, then will be the cheapest place where that product can be purchased by the consumers or being shopped by the broker and navigators. Certifying qualifying health benefit plans, again, consisting of multiple guidelines. There's still a major effort. One of the first project initiatives that we saw was NIAC's initiative around using our system called SERF, System for Electronic Records and Filing System. The SERF is being used primarily almost in every 50 states for property, casualty, and life for the approval of those products by the respective Department of Insurance commissioners. It is being expanded. Currently 25 states or so use SERF on a voluntary basis. There is still not a mandate, there is still not a requirement that you must use SERF. In fact, California made a statement that they will entertain different areas about how does the carriers can submit, how they can keep track of the status of their certification process, how they will be able to resolve those processes, and subsequently how they can ensure at any given time the rates and deductibles and whatnot is always going to be inaccurate and make sure that it meets the ongoing QHP requirements, especially on the rate side. The more in details, again, to the health plans, the carriers now, you have to follow the EHP requirements and develop your own QHP requirements, submitting the application, getting the applications being approved through monitorings, and the rate increases and certifications and decertifications is going to be ongoing challenges that the carrier must face with. And again, we'll talk about that. How does for instance, exchange portals can reflect and make sure that they are reflected the changes in rates based on different effective dates. Should the carrier decide to change their, for instance, rates and gets approved, yet exchange fails to post that information, there will be a lot of issues and discrepancies as one can imagine. From a MIDAS standards point of view, from overall CMS CSIO guidelines, we highly encourage our clients and our partners to follow the strict business processes. What you're looking at here is basically a business process model that ultimately is in charge of making sure that the carrier's compliance with the certified QHP process. So as you can imagine in here, that basically the Department of Insurance will initially provide the specifications of the essential health benefits. And those benefits are going to be then viewed by the health plans and then submitted back for the certification process. And the SERF will drive that effort altogether in some cases. In some cases, on the federally facilitated exchange, there is the talk of HIOS is being the intermediary, the way the plan data is going to be submitted for this certification process. Once the states are approved, then the QHP is then certified and it will be loaded to the exchange portals. It will be available for consumers or small groups to come in and basically purchase that product through the exchange portals. If the QHPs are not approved and need to be uniquely reviewed, there is going to be an appeal process just as you have it today, and perhaps an emphasis around the, once again, electronic tracking and tracing capabilities will be critical for the timely and accurate implementations of exchange participation. The other critical parts beyond that, once we have the QHP process, which has already started in California and New York, a few other states, the enrollment component to it, the portal aspect to it. So even though that in case of, for instance, California, that the ACA is mandating that presence of these things, in California actually they are already has announced that there will be 2 separate exchanges. Unlike the FFE model, there are some provisions around that. If you are a small group plan, you must have an individual. You must participate in an individual exchange. And there are some provisions tied into this aspect to it. But certain states in which we are seeing perhaps a little pattern as well too. So just from that kind of their existing insurance carrier base, the plans that are specialized on individual products perhaps will be more geared towards the individual exchanges, whereas the plans that are focusing in currently the small large group market will be more in tune with participating in the exchange markets. Once again, the income verifications and reporting requirements are going to be critical part of both exchanges. The tax credit, premium assistance credit payments, and reporting, risk adjustments, and the state's authority and flexibility for eligibility determinations are critical elements will be critical elements of the shop and individual exchanges. Finally, employer versus employee choice. As I mentioned before, in the private exchange world, we are expecting California to follow the same model, giving the option 5, which was what we call the employee option. In other words, that basically employers really, other than any kind of contribution that they can kind of pay-to-play model as it exists in Massachusetts, is that they will define their contributions, and hopefully then they will be very, very well eligible for some kind of a tax rebate, if you will. But the employees will then have the ability to choose a different tiers, meaning bronze and silver, gold, as well as different carriers. So they are not going to be controlled or limited by the employer's choice of the type of programs that they want to enroll in the shop exchange world. Now that we have a little bit of focus around that, so I would like to share with you some of what we are seeing, that the early adapter challenges that are being defined. A significant number of carriers still yet to take any actions about the exchange implementation. However, one thing to note is whether you are in a state-based exchange, operating on a state-based exchange, or you're running in a state partnership or federally facilitated exchange, there will be an exchange come January 1st, 2014. In fact, I'll answer that question in advance if anyone asks. We do not believe that deadline, January 1st, 2014, will be postponed. However, there is a conversation around to what extent the exchanges will be operational, functional, and successful. I guess the best answer that I heard was define success for me. It's a relative term. So I think that there will be varying degrees of success among the state-based exchanges. Some of them may have the complete functionality, all those capabilities that we described earlier. Then again, we think that there's going to be only very few of them. Others going to have maybe in a more of a partnership models. There is also the question about the certain states choosing to do what we call a web-based entity, in essence kind of outsourcing the entire exchange implementation to a commercial entity. Once again, Optum Connections is one entity. One organization is positioning themselves as a web-based entities. We're also seeing that some of the private exchanges who has been in business for quite some time, they are positioning themselves as a web-based entity to run the public exchanges on behalf of the state. To make the long story short, this is happening. I personally believe that this is the toothpaste is out. I don't think that we're going to be able to put this back into the tube again. So what is exchange integration, what it really means, and what are the challenges? Perhaps this slide really describes even at a very, very high level. So in a given state, in a given condition, that a payer organization will be basically interacting with the consumers or brokers or navigators who are buying your product, who are helping you sell the product, various products that are going to be marketed through the state exchanges. Again, this scenario also could be very well applicable to the private exchanges, minus the quote-unquote the federal exchange or federal data hub interface. And this, you can see in this model that there is going to be many touch points, starting with the plan product definitions are being shared across in a consistent matters. Today, there is no regulations around things like exchange must be the cheapest place than where I can sell the product. In the private exchanges, there are no governing rules around that. In the public exchanges, there will be. The enrollment process, there are talks around about how to overcome the challenges around real time. Once again, if you were to make the analogy to what I will call the Travelocity of the world, I don't believe they will be successful if they made your reservations on a nightly cycle, meaning that you make your go online, you buy a plane ticket, but you have to wait a day or two to confirm that you have your seat. Just imagine what kind of a chaos that will create. Yet the healthcare payer industry, it operates in the basis of basically batch processes. Even the private exchanges, even the best example we've seen is basically that they stage the data. It gives the feeling of a real time, but in essence, data is being staged and kind of processed still on a nightly cycle. Exchanges are real time. The Federal Data Hub is real time. Experian interface to identity and authentication is in real time. And just as that payment portion of it, especially payment through direct deposits or payment through a credit card portal implementation, will be all in real time. So how does the plans will do that? Let's take a look at it, what will happen if this carrier, if this payer operating in multiple states. And now you can see just by 2 states, now you have 2 sets of transactions that you have to deal with at any given time. And this is just 2 states. Obviously, we have some relationships with some of the early adopter payers that, again, they're approaching us. They're operating in 30 states and 15, 20 states. So the complications are no-brainer, to be very frank with you. It's a well-known type of problems as has been done in the past. The answer to this many-to-many, what we call it here is spaghettiware, if you will, is this what's called the enterprise service bus or service-oriented architecture. And this is the basic principle of other type of successful exchanges. In this case, in the Travelocity, in the travel business, as you know, the Sabre is the aggregator or connector, is the one that everybody talks and exchanges up all together. From a payer perspective, the exchange connector ultimately becomes your gateway to connecting your inner systems with the outer systems. This creates the layer of abstraction, layer of isolation. It removes the risk associated with making changes to your existing enrollment system, existing billing systems, and existing claims or even other systems that are going to be a critical component of the exchanges. As you can see here that the critical functions that payer systems will feed near real time or some cases in batch mode to the exchange connector. And the exchange connector's job, the responsibility is to consistently feeding that same plan management data, for instance, to across multiple state exchanges, federal exchange, even possibly to the private exchanges. And by the same token, that exchange connector gives the real-time interface capabilities. And provided that you will have the attempt and effort to, just as the kind of transformation taking place within the Medicaid modernization aspect to it or MMIS systems, as the systems becomes more real-time. I don't want to give some names, but almost every major core admin system vendor that we have spoken to in the context of this, what we call the exchange ecosystem, are making effort towards real-time enabling their system as the basis of communication. So that basically that systems like exchange connectors can then pass the information bidirectional in both ways and clearly simplifies and streamlines the process. So if you look at the exchange connector internals to it, once again, from the state partnerships, state-based or FFE-based exchanges, as the data elements, different type of processes that are going to be extended over the internet using protocols that are being defined perhaps partly by CISO and partly by the industry. We hope that the industry will come together and start forcing upon the adoptions of certain data protocols and connections among the different parties. And once that is completed, and the transparency or data sharing will become a lot trivial, a lot simpler, a lot manageable in that context altogether. Let me just go back to the exchange timelines, and this is pretty much the timeline as being defined both CSIO and various states. As I mentioned, that the QHP submittal process has RFPs has started, and to be completed by end of Q2 come May-June timeframe. Coincidentally, around I think we're going to see around around March-April timeframe of 2013 that there is going to be a series of RFPs and activities, both from the state side as well as the payer side, towards the establishment of the consumer portals. Perhaps initially with the individual, then the subsequently shop portals. And this will be then propagated to the consumer educational period. Just from a reference point of view, by the way, that the California is looking to spend $54 million alone on the marketing and outreach program for the purpose of educating the consumer. $54 million. Above and beyond the fees to Accenture will be collecting to building and operating the site. On the contrast, Arizona State Exchange, the amendment that they provided into their RFP was that their cost to implement State Exchange shall not exceed, I believe, $27 million total implementation, versus $54 million just for the educational aspect to it. Premium billing is the big elephant in the room. We do not believe that both the payers, even states, may have a great difficulties. It doesn't seem to be anything that out of the box, and you'll find a lot of anomalies, retroactive adjustments of any kinds and whatnot. All in all these implementations has to be, however, implemented and has to be delivered. And as a result of the final implementations or go-live date. As of right now, the open enrollments are scheduled still in the October-November timeframe, as you have been in the past for the other commercial products. And if all signs go, then the January 1st deadline, it still remains in effect and still possible to attain and meet. Again, there are some additional timelines. So just to kind of your checklist, what we'd like to do is there, when you go back to your desks, as our colleagues from the leading analyst firms always challenges us when we go back to our desk, make sure to ask these questions. Have you started your QHP certification process? Just because your state hasn't issued an RFP, hasn't defined the essential health benefits, the other states has been doing. And almost every state has kind of a golden standards, and you can expect that to be the quote-unquote the silver plan of your state exchange or of your federal facilitated exchange. There are critical components here. Most of them is going to be everything around electronic data feeds. Some of the carriers gone through the experience of building a kind of a plan repository. This is different than uploading the rate tables into your billing systems and enrollment systems. This is a repository of making sure the products, a kind of a catalog, if you will, all the product that you have, and making sure that the type of groups and type of plans that are going to be affected, what happens if we change the rate, what happens if we modify the deductibles, and so on and so forth. I think we're looking into a lot of these what-if analysis, just as the same experience that lived through the consumer retail business or the travel business. You can see how every day a plane ticket varies and changes in price. These kind of dynamic behavior, agile behavior, is making its way into the health insurance market as well. Next tasks that I will ask the audience to take a look at it is the step towards establishment of both enrollment, individual and shop enrollments. As you can see here is that there is the batch enrollment component to it. I didn't want to put anything contrary, but as some of you may be technical enough to know that the current data specifications that is in use, 5010 specs, is not going to be sufficient enough. So I think there's going to be a need for what we call it an 834 plus. There's going to be a need around the step-up, step-down routines and whatnot. Real-time, as I mentioned many times, is going to be a critical component of the system, especially on the group enrollment side. There's not a known data specifications or data dictionary for real-time web-based group enrollment processes. With that in mind, I will again ask audience to challenge your internal teams to adapt agile technologies. As you can see here, that you have basically just about a year to implement these systems in place. And oh, by the way, we do know that you're in the middle of an ICD-10 upgrades, and you're still perhaps in the 40-10, 50-10 battle altogether. However, adapting an agile technology is like the one shown in here. It will enable the insurance and to be able to react to it and being able to produce results within 90-day cycles. So we urge our partners, our clients, to adapt to models that you can have a 90-day implementation for perhaps QHP plan management. They'll bring that lessons learned into the enrollment cycle and strongly encourage to look into a COTS technology as commercial off the shelf. And you have most of the technologies. If not, companies like Softheon will be more than happy to provide you any kind of a support and guidance that you need. I'm about to wrap this up in our final slide in our continuation of our healthcare reform webinars. Our next session will be on January 16, and the session will be, I hate to do this, but it will be a lot more technical because it's now the time. It's the time of execution and time of delivery. And I will be joined by Craig LeClaire. He's the Vice President and Principal Analyst of Forrester Research. And on January 16, we will talk about the actual implementations of from our best practices. How does some of the early adopter carriers are looking, has been implementing, quote unquote, and participating in their future directions as the public and private exchanges. With that in mind, I thank you very much, and we have about 15 minutes for your questions.
Thank you. To ask a question via the web presentation, please choose the chat pod located in the lower left corner of your screen. Type your question and hit Send a Message button. At this time, we're going to address some questions that came in during the presentation. And the first question reads, how long have private exchanges been in existence?
As I mentioned in the slide, one of my slides is that the private exchanges has been around for quite some time, and some of them dating back to early 1990s. It initially grew out of maybe an extension of an HR capabilities within the large group settings altogether, and subsequently has been making its way into the consumer markets.
Okay, great. Our next question reads, can you share current state of subsidy processes, and will it be allowed in private exchange?
Subsidy exchanges right now is only defined within the context of public exchanges. Both that's the case in MassHealth Connector, Massachusetts, since 2006, and that's what's being written to law in the ACA. However, the subsidy component from an employee point of view can be analogous to a defined contribution that the employer may make, in that sense that the private exchanges as the only way that the employees will receive some reduction in their premiums only through the employer contributions or defined contributions as referred. Okay.
Our next question reads, what is the biggest challenge that health plans will face in participating exchanges?
I think the biggest challenge is going to be the technical aspect to it. Granted that the QHP plans, given the essential health benefits, there's only going to be a handful of. So we don't see that to be a difficult task. However, what is difficult is going to be when the exchanges start enrolling individuals on real-time fashion. The data has to be communicated round trip back from all the way from the portal to the back administrative system, to the premium billings, and back to the states, and so on and so forth. That kind of a real-time data exchange interface has not been implemented. Even in the most successful private exchange settings, once again, the data is staged, in some cases being processed on a daily, weekly, monthly basis. And that's going to be the critical part of the exchange implementations. And the second big part will affect the business is the what I will call the unknown fact. According to McKinsey, shop exchanges may entice anywhere from up to 50 million people to drop their commercial coverage and move to public exchanges. By virtue of that, the employer receiving tax benefit is going to be perhaps one of the greatest motivator for small business owners to choose the public exchanges over private exchanges. With that in mind, it's not, as carriers are not simply immune to the exchanges. Its exchanges is not about insuring the uninsured. It is a disruptive process. It will force the business to change inside out.
Okay, great. We have our next question that says, can you expand on how California is enticing brokers to sell HEX products?
Sure. As I said to you, is that I guess the biggest enticement will be that California is looking to pay the commissions directly to the broker. As everyone knows, that with the MLR constraints, brokers already feeling the pain, according to just quoting them. Many of them already decided they don't see the healthcare products as a profitable products to begin with any longer. Subsequently, in the exchange world, the complaint or concern that we are hearing from the broker community that if I sell an exchange product, it might be 90 days before I get my commission, considering that all that cycles has to go through. So another reason is that the exchange, as you know, California had a similar experiment dating back to around the time the Massachusetts Connector started. But the brokers were not part of that initial solution. And unfortunately, that experiment did not succeed. Kind of lessons learned this time around, California is looking to entice them every possible way, including offering different types of product on the exchange. That also addresses the California's vision to become as self-sustaining. As you know, the grants and subsidies that the states will be receiving to run and operate and build these exchanges will be pretty much diminished, if not all gone, beyond 2016. So the sustainability aspect is also a big concern to exchange. So kind of hand in hand, creating an overall marketplace, not just for health insurance products, the QHPs, but also for HSA, HRAs, and COBRAs, is already in the consideration of California exchange.
Okay. Why should health plans look at QHP from a more strategic perspective?
I think that's a great question. Once again, as I mentioned earlier, that SBC was the first mandate came out. The summary benefits and coverage basically dictated the carriers to provide the standard information, the carrier information, the plan information in a standard 8-page, down to the font size, down to the page size. And many carriers that today they comply that rule based on literally filling out these documents by hand manually. Clearly, this day and age, there's a strong need for electronic single records, what we call it a system of truth, so to speak. So the QHPs has to be viewed as a strategic component to it, not just for the exchange product, but also the product that are being sold on a private exchanges or even through the brokers. so that in the case of that, once again, providing, imagine a store that has 100,000 products on the shelf. And there has to be a cost associated with it. Cost may not be associated with directly buying and selling the product, but overall maintenance, IT cost, total cost of ownership, not to mention the risk factor associated with those implementation. So we urge our clients to look at the QHP in the context of an overall strategic plan management project, not just for state exchanges, but also include the public exchanges or even your commercial product lines.
Okay. And the next question we have come in says, does accreditation and quality reporting, HINDIS reporting, apply to both the private and public exchanges?
The answer is yes, but in different ways. On the public exchange side, both the, again, as I said, accreditations by URAC and CQA, and probably the part of the HIDIS is going to be at some point in time, if not already. I do apologize. There are so many rules and regulations that are being published any given day. It's critical because even information like, for instance, claims analytics is being viewed as a critical component of carrier's ability or eligibility to be a QHP in a given respective region. That was very clear from the California RFP, as well as the New York State Exchange implementations. On the private exchange side, is the critical factor is really ties into the overall quality initiatives and how it relates to the CMS star ratings, especially on the Medicaid Advantage programs. As you know quite well, there is going to be a sweeping rules and regulation changes in 2013 that will be highly encourage the consumers to kind of leave off poor star rating plans and move to high star rating plans based on those quality and accreditation processes or outcome of those processes.
Okay. And our next question reads, what are some of the critical timelines in exchange implementation?
As I mentioned earlier, so if I may say that basically end of Q1, the carriers must be ready to submit their QHPs. And again, it's just having the opportunity. There could be a one person enrolled for the exchange, or it could be 1,000, or it could be, I don't know, maybe 1 million in some states perhaps. It's an effort, nevertheless, should not be overlooked. So the plans has to be, carriers has to be ready to submit their QHPs by no later than, I will say, the March, April timeframes. And in line of that, the next big tackle will be the development of the portals. There is going to be a significant effort towards on the public space, and for those regions, certain demographics that private exchanges will actually be a way to come back and a way to compete with public exchanges. Case in point, that there are several examples that initiatives that are being even put together by the likes of Bloom Health and others, coming together, multiple carriers forming their private exchanges. So those are the critical timelines, and the subsequently, again, as I said, the big elephant in the room will be premium billing. Vendor selection, implementation. For a premium billing system alone, it can take several months. So sooner you can start to process, better position I think that the carrier will be.
Okay, great. We have one last question that says, what are aspects of QHP that SURF is not planning to address?
Initially, SURF made a commitment to. SURF is a fairly decent functional system. What it lacks, however, is the real-time aspect to it, is a system-to-system interface. Unlike the significant portion of the Federal Data Hub and FFE will be based on a real-time communication between the systems. This is a whole new territory for SURF. They have received some funding from some of the early adopter states to help build this UDISM interface with the support and guidance from NIAC. The insurance commissioners come together and they felt the need that there has to be a consistent way that carriers can submit their information, and that process, it's a kind of a workflow process, lack of a better term, will be all handled and processed and operated by NIAC. The challenge there is they are already saying that they are not going to be ready for the system interfaces. So therefore, the significant amount of data, and there are published documentations and quote-unquote the surf data dictionary, that has to be manually entered and captured through the system by the respective parties, carrier organizations, the actuarial people, the product planning and finance and whatnot. So the inability to capture that information electronically, inability to communicate that information back to the carrier is going to be the hindrance aspect to it. Subsequently, the AV calculators, actuarial value calculators, is going to be, we don't know yet if there is going to be a critical element of the surf process or it will be handled as a subsequent kind of a down select product process within the workflow.
Okay, great. Thank you for that great presentation and for sharing your thoughts today. Thank you to the audience for participating in today's conference. That concludes this webinar. Thank you again, and enjoy the rest of your day.